Fibrolamellar carcinoma, age group 5 to 35 years. The no predisposing factor, nobody knows why it comes. Or solitary, so lobulated, well-defined tumor. So one of the characteristic is that it's lobulated liver tumor, and this also has a central scar like that of focal nodular hyperplasia. So in both focal nodular hyperplasia and fibrolamellar carcinoma, we find a central scar. But in fibrolamellar carcinoma, this scar contains calcifications in 50% of cases. This is not a hypervascular lesion. Therefore, there is moderate enhancement of the lesion followed by, as usual, the scar shows delayed enhancement like that in focal nodular hyperplasia, but the lesion itself on the whole shows moderate enhancement compared with focal nodular hyperplasia, which is a hypervascular lesion. The prognosis for this condition is good. It is a non-cirrhotic. This can occur in non-cirrhotic livers, large lesion, and you can see fibrous bands through the lesions apart from the central scar. So we have a scar and the fibrous bands and calcification in the scar, and seen in non-cirrhotic liver in young patients. So all these points towards the diagnosis of fibrolamellar carcinoma. So we have to differentiate between focal nodular hyperplasia and fibrolamellar carcinoma. So we are using an MRI. We can see in focal nodular hyperplasia, it's the hyperintense on T2, and the scar calcification, which is common or noted in fibrolamellar carcinoma, is rarely occurs. You can keep it as a negative for focal nodular hyperplasia. And focal nodular hyperplasia is usually asymptomatic. Whereas the biopsy is the confirmation. FNH, being a benign tumor, shows normal hepatic tissues, whereas fibrolamellar carcinoma is a malignant lesion. So it contains malignant cells and eosinophilic hepatocytes. We can remember that. It can be used in differentiating pathologically. So we come to the last lesion, which is metastasis. These are most common tumors of the liver. Most common metastatic site in the whole body after the lymph node is the liver. So the second rank in getting metastasis. The multiple lesions. Metastasis can be divided into hypervascular and hypovascular mets. So the DD for hypovascular mets includes adenomas, HCC, the routine normal typical HCC, hemangiomas, etc. Whereas for hypovascular mets, you get focal fatty infiltration, abscesses, atypical hypovascular HCC. So any lesion with low blood supply will produce a hypovascular met, whereas a lesion with increased blood supply will produce hypovascular metastasis. So from the other parts of the body, we can see renal cell carcinoma, thyroid cancers, carcinoids, melanomas, islet cell tumors, choriocarcinoma. All these are hypervascular mets causing tumors. So next we move to calcified mets, seen from mucinous carcinomas. You have to remember calcified mets, you have to remember mucinous. Carcinomas of GI tract, colon, stomach, rectum, along with melanoma and ovarian cancer. We can see melanoma occurring in both hypovascular mets as well as calcified mets. That's something you can note. So cystic mets commonly seen with ovarian tumors and colonic carcinoma. Okay, cystic mets of the liver causes